Okay, good afternoon and good evening. I would like to welcome you to this ESSO and Clinical Surgical Oncology webinar. Can you have this first slide, April, please? Thank you very much. We just started with the first slide. April. Right. So this is an ESSO. Right. April, would you mind showing the first slide, please, to start the webinar? Thank you very much. The very first one. Thank you. April, would you like to show the first? Thank you very much, April. So it is an ESSO Clinical Surgical Oncology webinar on de-escalation of axillary surgery and personalized neoadjuvant approaches. This is a joint work between ESSO and Jahui Medical Research and Education, who are two partner organizations, and running also the Clinical Surgical Oncology journal itself. And if I can have the next slides about the journal, please.
Can you see the slides?
Yes, so Clinical Surgical Oncology is a journal hosted by Jahui International Hospital and published by Elsevier. It is next slide, please, a peer-reviewed journal publishing on education, training, and also research in surgical oncology. If we can have the next slide, April, please. Thank you. It is an internationally peer-reviewed journal, and it is also meant to promote surgical oncology advancements. It has an international editorial board with over 10 countries with board members and editorial board members from 10 countries, with an editorial board run from China, and we have two editors-in-chief and an editorial team with international members. This webinar is one of our educational webinars on breast cancer management, and I would like to ask Nicola now just to take the lead on the webinar itself. Thank you very much.
Yes, thank you, Tibor, for your introduction, and good morning, good afternoon, or good evening to everyone. Thank you for joining us in this joint webinar with JMed, CSO, and ESSO. So we will start now with a brief introduction, with a brief video from the European Society of Surgical Oncology. So please, Tao, if you can share the video, and then we will go on with the webinar.
ESSO is a diverse and inclusive community fostering connections among surgical oncology experts worldwide. ESSO community counts 4,500 plus members. Global membership with 25 national affiliated societies. Our mission is to advance the science and practice of cancer surgery through education, research and innovation and multidisciplinary care in Europe and beyond. Through our courses and webinars, we train surgeons and healthcare professionals on the latest advancements in their field, new surgical techniques and surgical research. Our specialized European schools offer structured training in the management of peritoneal neoplasms, soft tissue sarcoma surgery, and breast cancer surgery. With a passion for innovation, our research academy aims to promote surgical oncology research and collaboration among healthcare professionals, researchers, and patients. To support the next generation of surgical oncologists, a growing network of young ESSO was established to connect junior surgeons and help them play an active role in the future of surgical oncology. Through our educational grants, we provide young ESSO members with opportunities for learning and research development. With this vibrant community of dedicated professionals, we organize the biggest annual surgical oncology congress in Europe to stay at the forefront of innovation. Our commitment to advocacy ensures that the voice of surgical oncologists is heard, influencing decision makers and shaping healthcare policies. At ESSO, we unite surgical oncology experts across the world, all with one common goal: enhance the quality of cancer care, cure cancer together. Follow us at essoweb.org.
Nicola, you are muted. Can you unmute?
Yes. Thank you, Tao. Yeah, so if you would like to be part of this big network of breast cancer surgeons all around the world, I invite you. Can you see the slides?
Yes, it's good.
Okay, I invite all of you to apply and subscribe for your participation in the European Society of Surgical Oncology in order to access knowledge and to benefit also from reduced rates for the ESSO Congress and for all the ESSO educational activities. So become a member of ESSO. You can scan the QR code here, or you can connect to the website. You will also have publication advantages with the European Journal of Surgical Oncology. You could have also opportunity of career growth for applying for educational grants from the ESSO, and also for research opportunities, accessing to experts guidance, and for be guided to develop your research projects. You will join a global network of more than 4,000 leading oncologists and breast surgical oncologists from all over the world. And I also invite you to apply for the EBSQ examination in surgical oncology. This is an exam done by a written part and an oral part organized by the Division of Surgical Oncologists of the Section of Surgery within the European Union of Medical Specialists, with the support of the European Society of Surgical Oncology. And the European Board of Surgery Qualification Exams leads you to a prestigious title of Fellow of the European Board of Surgery. So apply also for the exam if you didn't done yet. The European Journal of Surgical Oncology is the official journal of the ESSO, and ESSO members will have exclusive access to the European Journal of Surgical Oncology and a discount on the open access publication fee. And I also invite you to participate in all our courses organized by the ETC, the Education and Teaching Committee, the working group, in which I'm pleased to be part, together with Hélène Borg. And this year, we will have the ESSO Advanced course on oncoplastic breast surgery with leading breast surgical oncologists and breast oncoplastic surgeons coming from all over the world. This year, we will have this course in Madrid from the 21st to the 23rd of May at the Clínica Universidad de Navarra in Madrid. And then I'm pleased also to invite all of you to apply for the ESSO course on ultrasound in breast cancer surgery. I will organize this course together with Joseph Wolders from the Netherlands in Cremona, Italy, the 28th and 29th of September, for the use of ultrasound for surgeons. Ultrasound is a useful surgical tool in order to localize non-palpable lesions, but also in order to control margins in your surgery. And then the ESSO Advanced course on breast cancer surgery in Vienna, the 22nd and 24th of October this year, just before the exam of the European, of the EBSQ exam for breast surgery. And then I also invite all of you to our Congress, the 45th Congress of the European Society of Surgical Oncologists, that this year will be done in Madrid, will be organized in Madrid from the 4th to the 6th of November 2026. So we can start now with our program of today. We are pleased to have with us Hélène Borg. She's a breast surgical oncologist working at Mater Dei Hospital in Malta. Then I'm also pleased to have with us Mario Giuliano, that is a medical oncologist working at the University Hospital Federico II in Naples, where I serve as a breast surgical oncologist. And Xin Wang, a medical oncologist coming from the National Cancer Center in China. So, Mario, it's my pleasure now to introduce you and to give you the screen for the first talk of this webinar, that is Tailored Neoadjuvant Approaches in Breast Cancer Management. Thank you, Mario. The screen is yours.
Thank you, Nicola. For some reason, I have technical difficulties in sharing my slide. It doesn't allow me to share the slides. So maybe meanwhile that I fix this problem, we could move on if we don't hear you.
Now probably is fixed because I saw some other slides. Now it should be possible to share. Okay.
Yeah.
Then I also, sorry, Mario, just before starting, I invite all of you, all the participants, to share your questions through the question and answer toolbox. And in the end, we will have 10 minutes of discussion in order to discuss and to share your questions with our experts. Thank you.
Please let me know if you can.
Yes, we can see your slides. You can start.
Okay.
Thank you.
Thank you very much, Nicole, and a special thanks to the organizing committee for giving me this opportunity to share with you a very brief overview on tailored neoadjuvant approaches in breast cancer management. I have to go on. Here, my disclosure. And we are all aware about the important advantages and opportunities of neoadjuvant approaches, especially in terms of de-escalation and optimization of breast and axillary surgery. But there are additional important clinical benefits that may impact also long-term outcome. First of all, we know that neoadjuvant approach may give us the possibility to change treatment if no response or even progression of disease occurs. It provides the possibility to gather prognostic information at the individual patient level based on response to treatment. But most importantly, it gives us the possibility to further tailor the adjuvant post-neoadjuvant treatment based on pathologic response. And finally, it represents an excellent research platform to develop new treatments and identify predictive biomarkers. All these advantages have been demonstrated primarily in HER2-positive early breast cancer. And for this reason, with the exception of very small non-negative tumors, neoadjuvant approach should be the preferred choice, especially for tumors larger than 2 centimeters and or with nodal involvement. The use of neoadjuvant treatment in CT1C and 0 tumors is still debated, as it may represent an over-treatment, at least in some cases. However, recently, de-escalated neoadjuvant systemic treatments are currently being developed in several clinical trials. And for example, for a long time, we had standard neoadjuvant treatment based on anthracycline, sequential anthracycline and taxane-based chemotherapy. Several trials, such as the TRIFINA, the TRAIN2 trial, have established an alternative standard with the anthracycline-free regimen consisting of sequential taxane and carboplatin-based chemotherapy with dual HER2 blockade, including trastuzumab and pertuzumab. However, these regimens are still pretty toxic, so more recent trials have evaluated the possibility of further de-escalation of chemotherapy backbone together with dual HER2 blockade, which hereafter I will refer to as HP. And one of these trials, an important phase 3 randomized trial, is the recent NeoCAR-HP study, which randomized 774 patients with HER2-positive early breast cancer in stage 2 and 3 to receive either standard combination of taxane and carboplatin plus HP for 6 cycles, or just taxane plus HP for 6 cycles. Primary endpoint was pathologic complete response. This was a non-inferiority trial. And the study was positive as it demonstrated that de-escalated regimen of taxane plus HP was non-inferior in efficacy and, as expected, much better tolerated than the standard treatment, including also carboplatin. And these results were present both in patients with the hormone receptor positive and in those with hormone receptor negative tumor. However, more than 70% of patients enrolled in these trials had stage 2 disease. So despite important, this result may not be completely generalizable to patients with a high tumor burden. And talking about patients at higher risk, at the ESMO meeting in 2025, the primary results of the important Destiny Breast 11 study have been presented. This is the first trial testing the novel antibody drug conjugate trastuzumab deruxtecan in the neoadjuvant setting in early breast cancer. The study randomized over 1,000 patients to receive with HER2-positive disease at high risk of relapse, meaning with high tumor burden, to receive either standard sequential treatment with anthracycline and taxane plus HP, or trastuzumab deruxtecan for 4 cycles, followed by the taxane plus HP for 4 cycles, or trastuzumab deruxtecan for 8 cycles. This third arm was discontinued due to several reasons, including lower clinical activity. The primary endpoint was pathologic complete response. And the study was positive, since it demonstrated a statistically significant and clinically meaningful improvement in pathologic complete response rate in the ITT population, with an absolute difference of 11.2%. And in the hormone receptor negative subgroup, trastuzumab deruxtecan showed an impressive pathologic complete response of 83.1%. So based on these important results, trastuzumab deruxtecan followed by paclitaxel plus HP may represent a new standard of care as neoadjuvant treatment for early breast cancer patients with HER2-positive disease at high risk of relapse. However, we need to understand how to reconcile these important results in terms of efficacy with the concurrent efforts toward the escalation of treatment to achieve less toxicity. For sure, clinical pathological features such as tumor sites and nodal status can help tailoring the neoadjuvant treatment. However, ideally, an optimal decision-making should incorporate also biological characteristics in order to better tailor the treatment, maximize the efficacy, but also preserve patient quality of life. And one potential tool to guide treatment decisions in a biological-driven way could be HER2-DX genomic test. This is a multi-gene signature that analyzes the expression of 27 genes combined with clinical data like tumor sites and nodal status. And when adopted at the baseline before surgery, it provides 3 important scores: risk of relapse, addition of the HER2 signaling, and most importantly, likelihood of pathologic complete response after neoadjuvant treatment. And in a recent meta-analysis of neoadjuvant trial, HER2-DX genomic tests show that the possibility to identify those patients who can benefit the most from multi-agent chemotherapy together with dual HER2 blockade versus single-agent chemotherapy, so de-escalated single-agent chemotherapy plus dual HER2 blockade. These results suggest the potential utility of this genomic test in guiding treatment intensity in a biological way, assuring high efficacy and low toxicity for the tailored treatment. And the possibility to use the HER2-DX genomic platform to guide treatment decision is currently being investigated in the phase 3 definitive trials, which enrolls patients with HER2-positive disease in stage 2 to 3 eligible to neoadjuvant treatment, and randomize them to receive either neoadjuvant treatment according to physician choice and local guidelines, or tailored strategies according to the result of HER2-DX in terms of PAT, CR score, and risk score. Importantly, this study has 2 co-primary endpoints: PAT CR rate and quality of life. And these represent an important paradigm shift in our treatment goals, not just aiming to maximize the efficacy, but also to preserving quality of life. Let's move now to early triple-negative breast cancer. In this case, upfront surgery can be considered for very small, including T1A and T1B, node-negative tumor. For T1C and 0 tumor, the optimal strategy is still debated. However, neoadjuvant chemotherapy could be preferred given the high probability of achieving pathologic complete response with a standard neoadjuvant chemotherapy based on platinum taxane followed by anthracycline. Moreover, with this approach, we can further escalate treatment in the adjuvant setting in patients with residual disease who are at higher risk of relapse. And finally, for larger tumors or in presence of nodal disease, the standard of care should be always neoadjuvant treatment with chemotherapy plus immunotherapy, given the impact of this approach not just on the possibility of response, but also on long-term outcome. And this evidence comes from the phase 3 randomized Keynote 522 trial, which randomized patients with tumors larger or equal than 2 centimeters and or nodal involvement to receive either standard chemotherapy or chemotherapy plus the PD-1 inhibitor pembrolizumab. Patients enrolled in the experimental arm also received the pembrolizumab after surgery for up to 9 cycles. Co-primary endpoints of the trial were pathologic complete response rate and event-free survival. And the study was very positive as it showed a statistically significant and clinically meaningful improvement in pathologic complete response in ITT population, which reached with pembrolizumab 65%. Importantly, this benefit was observed both in patients with PD-L1 positive disease and in those with PD-L1 negative disease. Moreover, we observed also with pembrolizumab an improvement of event-free survival, both in patients achieving a pathologic complete response and even more in patients with residual disease. And finally, there was also remarkable improvement in overall survival, favoring the arm with pembrolizumab. So this study established the new standard of care for patients with the triple-negative breast cancer eligible to neoadjuvant treatment, despite the fact that the KEYNOTE-522 regimen is still pretty toxic. So de-escalation, at least of the chemotherapy backbone of this neoadjuvant treatment, should be evaluated, at least in patients at lower risk. And so once again, biology could guide this de-escalation and optimization of treatment. In particular, the novel TNBC-DX genomic test is a multi-gene signature incorporating the expression of 14 genes with clinical information relative to tumor sites and nodal staging. It gives us two important outputs: risk of relapse and probability of pathologic complete response. And then in the neoadjuvant phase 2 NeoPACT trial, TNBC-DX was evaluated in patients with early triple-negative breast cancer in stage 1 to 3, receiving a de-escalated anthracycline-free regimen with carboplatin plus docetaxel plus pembrolizumab. Among the patients with the availability of the TNBC-DX test, the risk score was strongly associated with both event-free survival and overall survival, and also the PAT-CR score accurately predicted the probability of pathologic complete response. So these results may support the clinical utility of this novel genomic platform as a tool to guide a de-escalation and optimization of neoadjuvant treatment also in triple-negative breast cancer. Let's finally move to luminal early breast cancer, where the treatment strategy is still primarily driven by clinical stage. In particular, for CT1 and T2 and 0 tumors, upfront surgery is generally preferred, reserving the neoadjuvant approach for selected cases. In contrast, in presence of larger tumors and/or with nodal involvement, the neoadjuvant treatment strategy should be preferred, at least in patients who are anyway eligible to and candidate to adjuvant chemotherapy, and in general in those with who have higher aggressiveness of disease, in particular, for example, patients with lower expression of estrogen receptor. In these cases, the neoadjuvant approach can be based on standard anthracycline and taxane sequential chemotherapy regimen, and in selected cases, neoadjuvant endocrine therapy alone, like, for example, in postmenopausal patients with luminal A-like tumors. And finally, in locally advanced inoperable disease, primary systemic treatment should be the favored choice in any case. And the treatment could be based on standard chemotherapy, anthracycline and taxane base, or as an alternative on the novel combination of endocrine therapy plus CDK4/6 inhibitors, which is already approved in this specific indication. But this novel combination has been tested also in patients with operable luminal breast cancer, in particular in several trials in comparison with endocrine therapy. And in all trials, it showed an improvement in clinical biological activity, especially in the capability of cell cycle arrest. But in no trials, there was also a consistent improvement in clinical responses. Moreover, in trials testing CDK4/6 inhibitor plus endocrine therapy compared compared with the standard chemotherapy, the PAT-CR score were generally similar among arms and were generally very low. So to date, at least in operable luminal breast cancer, the combination of CDK4/6 inhibitor and endocrine therapy remains investigational. So we should understand how to move forward in tailoring in a biological-driven way the neoadjuvant approach also in luminal breast cancer. And again, the answer could be moving upfront before surgery, before at the time of diagnosis, the use of multi-gene signatures such as Oncotype DX. Indeed, the low genomic risk evaluated by Oncotype DX can predict sensitivity to neoadjuvant endocrine therapy. On the other hand, high genomic risk and younger age can predict higher probability of nodal pathologic complete response after neoadjuvant chemotherapy. So if we could use this genomic platform before starting any treatment, we could have the possibility to tailor in a biological-driven way, not just the type of systemic treatment, but the entire multidisciplinary approach. So deciding the timing and the type of surgery, and deciding the timing of systemic treatment and the type of systemic treatment. So in conclusion, neoadjuvant approach enables optimization of surgical procedures and allow us to tailor systemic treatment according to individual patient risk. In HER2-positive and triple-negative early breast cancer, novel combination treatment allow to achieve high PCR rates, supporting the surgical de-escalation and improving long-term outcomes. In luminal breast cancer, the combination of endocrine therapy plus CDK4/6 inhibitors may substitute, at least in selected cases, the standard chemotherapy. But the most important thing is that the tailoring of treatment could be allowed if we use the upfront multi-gene signature that may guide the entire treatment strategies and helping us to select the best treatment in terms of efficacy, but also in terms of toxicity. And with this, I thank you for the attention.
Thank you, Mario. Thank you. Really an outstanding presentation. And you raised several points that we can discuss at the end, particularly using the genomic testing upfront. This would be very, very helpful in order to optimize our treatment from both the medical point of view, the medical oncologist point of view, and the surgical point of view. So let's now move to Hélène Borg from Malta, breast surgical oncologist, and let's see how these primary systemic therapies could impact in performing a risk-adapted and response-adapted surgery. So please, Hélène, particularly for the axillary surgery. Please, Hélène, the screen is yours. You can share your slides, and then I remember to all the participants to take the opportunity to interact with us, to answer to ask questions, because you have great experts with you today, so don't miss this opportunity.
So I'm trying to share my screen, but hold on.
Okay. Let's in the meanwhile, if we had some problems with sharing the screen from Hélène, Mario, can I just take some minutes or some seconds to ask you a question? We have the first question from the audience about neoadjuvant endocrine therapy. I know that is not an easy question and a very short answer, but what do you support neoadjuvant endocrine therapy in postmenopausal and plus luminal breast cancer? This is the question.
Okay. I support this treatment, especially in elderly. But if the nodal involvement is large, if there is a high burden of disease at nodal level, I would support the combination of endocrine therapy plus CDK4/6 inhibitor, because in this case, we could have a treatment that allows us also potentially to de-escalate the treatment. The problem is that right now, as I said, this combination is not, at least in Italy, reimbursed for operable breast cancer. But in presence of high burden of nodal disease, I would combine endocrine therapy with CDK4/6 inhibitor. And then we would have additional tools to use endocrine therapy alone, for example, repeating biopsy and looking at the reduction on Ki-67. This could give us the possibility to continue to keep going with endocrine therapy, even without CDK4/6 inhibitors as a neoadjuvant treatment.
Very clear. Thank you. We will further discuss in the end. Now it's time for Hélène. Please, Hélène.
So I am an oncoplastic and breast surgeon, not a histopathologist, just to clarify. So this is on the escalation of axillary surgery. I have no disclosures. So as regards evolution of axillary surgery, go ahead and tell us that where at the time they used to do already. So hold on.
We could see your slides. You can put it in. You can continue sharing. Yeah.
I think there's some kind of voiceover. So.
Yes, there were some voices, but you can go on. You can put in presentation mode.
I'll do it like this, maybe better. So as regards evolution of axillary surgery, first we start off with axillary node clearance. Originally it was radical surgery. So they used to remove all of the breast tissue, including the muscle, the underlying muscle, and the level 3 axillary nodes. However, this caused a lot of problems, including lymphedema, and there are different stages of lymphedema. There are 4 stages. We recognize that less sometimes is better. With NSABP04, what they managed to do here is, instead of radical mastectomy, they assessed total mastectomy with irradiation or total mastectomy on its own without any axillary surgery. Those patients who had negative nodes showed after 25-year follow-up that there was no significant difference as regards to disease-free or relapse-free or distant disease-free or overall survival. So then we go to sentinel lymph node biopsy. In this case, we're only removing the sentinel nodes, which are the first draining nodes. There are different techniques on how we can do that. Some cases we can use technetium, so dual technique with technetium and methylene blue or patent dye. In some cases, we use ICG, and in some cases, MEC can be used. There are different techniques, and these are only some of them. The next step is, so before we used to do sentinel lymph node biopsy, and if positive, then we proceeded with axillary lymph node dissection. However, we recognize that instead of doing axillary lymph node dissection, in some cases, we can also do radiotherapy. This is a seminal trial, the Z11. And in these cases, those with positive lymph nodes, they were assigned either to no further surgery or else to axillary node dissection. And they found no difference in overall survival, disease-free survival, or local regional recurrence. However, there are, of course, some caveats, one of them being they received whole breast irradiation. What they noticed as well is in the arm where they did not do any axillary node dissection, they had reduced morbidity. This was further confirmed with the Amaros trial, which is a phase 3 randomized clinical trial, and they assigned patients for axillary radiotherapy or else axillary lymph node dissection. At 10-year follow-up, there was no difference in overall survival or disease-free survival. However, they noticed that there was reduced morbidity in the radiotherapy arm. The IBC SG1093 further confirmed the findings at the Z11 trial. Basically, it is a multicenter randomized non-inferiority trial, follow-up of around 10 years, and it confirmed again that we support the practice of omitting axillary node dissection when there is sentinel lymph node involvement. In cases where there was patients needed chemotherapy, if they had positive nodes, they used to be sent for chemotherapy, and then they come back to the surgeons and we do axillary lymph node dissection. We recognize that targeted axillary dissection can be done. So the nodes which are involved, they used to be clipped, so we mark them. The patients are sent for chemotherapy, and then after chemotherapy, they have a marker inserted, which can be RFID tag, it can be MACSeed or Scout, etc., or even wire. And we remove the involved node together with 3 sentinel nodes. And we recognize that targeted axillary dissection has equivalent outcome as if doing an axillary lymph node dissection. Now we arrive to a point with de-escalation whether sentinel lymph node biopsy can be omitted or not. And there are some trials which are supporting this. There are 3 important ones: the SOUND trial, the INSEMA, and the Dutch trial, the BOOK 20138. And what they are assessing is breast conservation. Patients who are going to undergo breast conservation surgery, they need to be small tumors. In SOUND, it's T1, in INSEMA, it's T1 or T2. Same with the Dutch trial. Any receptor status, and the endpoint ranged from regional recurrence to invasive disease-free survival or distance-free survival. Going to the SOUND trial, this is a phase 2 randomized control trial, which was published in 2023. It included 18 European hospitals and randomized patients to either sentinel lymph node surgery or else no axillary surgery. As we said, up to T1 in cases of SOUND trial, so up to 2 centimeters in size, clinically node negative patients, and they were assigned for breast conservation surgery and radiotherapy. To recruit these patients, they had to have no axillary abnormalities, and if there were any doubts, patients had FNA of these axillary lymph nodes, and they had to be negative at FNA. 1,406 were negative on ultrasound, and 57 were negative on FNA. The median age was 60, and tumor size 1.1, so on the lowish side, and patients were ER positive and HER2 negative in 87.8%. This is important because the majority of patients, therefore, were postmenopausal, ER positive, HER2 negative with small sized tumors. From the sentinel lymph node group, 13.7% had positive nodes, 5.1% had macromats, 8.6% micromats, 2% had more than 2 positive lymph nodes, and only 0.6% had P2 disease, which means that more than 3 nodes were positive. 20.1% of sentinel group and 17% of no axillary surgery group received chemotherapy. 98% of the sentinel group and 97.6% of no axillary surgery received radiotherapy. 83.3% versus 81.1% had whole breast radiation over 3 to 5 weeks, 10.7 versus 10.8 had partial breast radiotherapy, and 3.4 versus 5.6 had intraoperative boost followed by hypofractionated course. So these are the results. The green line is the sentinel node group, and the golden line is the one which received no axillary surgery. And there was no difference as regards distant disease-free survival. We're looking now at disease-free survival, and again, there was no statistical significance. And this is the overall survival. Again, no statistical difference, and these are the p-values showing no statistical difference. So what have we learned from the SOUND trial? So patients with small breast cancer with normal-looking lymph nodes on ultrasound can be spared axillary surgery as it doesn't really affect the adjuvant treatment. Axillary lymph node does not provide therapeutic benefit. In the no axillary group, the cumulative incidence of lymph node recurrence in the axilla was very low at 0.4%, despite a 13.7% rate of nodal involvement in the sentinel node group. We're going to move to the INSEMA trial. It was a prospective randomized non-inferiority trial, T1 or T2, again, breast conservation surgery and omission of axillary surgeries compared to sentinel lymph node in clinically node-negative patients. 5,502 eligible patients. They were randomized 1:4, meaning majority went to the sentinel lymph node group, whilst 1/4 were assigned to the no sentinel lymph node biopsy, and median follow-up was of 73 months. And you can see there was no statistical difference at the endpoint of invasive disease-free survival. So what have we learned from the INSEMA? So 5-year invasive disease-free survival, 91.9% in the no sentinel group and versus 91.7% in the sentinel lymph node group. No sentinel lymph node biopsy group had lower incidence of lymphedema, greater arm mobility, and less pain with movement of arm or shoulder, which does affect quality of life of patients. So the conclusion is omission of surgical axillary staging was non-inferior to sentinel lymph node after a median follow-up of 6 years. This is the Dutch trial. They recruited 1,733 patients. Again, hormone receptor positive, HER2 negative, clinically node negative. They had to undergo breast conservation surgery with whole breast radiotherapy. They were randomized to either sentinel node or else no axillary surgery. And the results were presented at the San Antonio in December 2025. Median follow-up of 5 years in 1,573 evaluable patients. Cancer recurrence in the lymph node 0.5% with the sentinel node versus 1.2% with those not undergoing any axillary surgery. Regional recurrence-free survival 96.6% with the sentinel node group versus 94.2% without sentinel node. Both were not statistically significant. So in conclusion, sentinel lymph node omission can be safely considered in those who are more than 50 years of age, who are hormone receptor positive, HER2 negative, grade 1, grade 2, T1 tumors. In cases of ductal carcinoma in situ, generally we do not do axillary surgery. The only cases where we do axillary surgery in cases of DCIS is when it's a palpable tumor where we're suspecting a high risk of microinvasion, or is when the patient is going to undergo mastectomy. In that case, we offer sentinel node. And there is supporting evidence that we might even consider foregoing sentinel lymph node biopsy in cases where the biopsy confirms this to be ductal carcinoma in situ. So what are the roles of sentinel lymph node biopsy? Does it play a role in survival? As we saw in the NSA-BP P04, no, it doesn't. Does it offer local control? No, and this can be backed by the sound INSEMA and the Dutch trials. Does it play a role in therapy decision? So in some cases, yes, especially if one is planning regional radiation, chemotherapy selection, or for CDK4/6 inhibitors. However, most adjuvant treatment recommendations are tailored to biology of disease rather than the risk of recurrence. I'll take you to the RX responder. So basically, in these cases, depending on the recurrence score of oncotype, those patients who are postmenopausal have no benefit of chemotherapy as opposed to endocrine on its own. However, in cases of premenopausal, there is a benefit of giving chemotherapy in the select group. So perhaps in the select group, sentinel lymph node can still be considered for them to qualify for the RX responder trial result. So the take-home messages, we can consider omitting sentinel lymph node biopsy in postmenopausal patients with small cancers, low grade ideally, and the hormone receptor positive and HER2 negative. Heavy axillary tumor burden is uncommon. It was quoted as around 0.4%. And sentinel lymph node biopsy is not needed for local control. De-escalation of surgery causes less axillary arm morbidity and better quality of life. Exceptions where nodal status is important for systemic therapy is in cases of post-neoadjuvant chemotherapy patients when there is presence of metastatic sentinel nodes and it can affect chemotherapy regime. So it's always important to involve, as part of the multidisciplinary team, the oncologist as well. In cases of HER2 positive patients, when it's less than 1.5 centimeter and they are not going to receive neoadjuvant chemotherapy first, and the reason is in HER2 positive patients have a higher tendency of having axillary node metastasis. And to determine the need for regional node irradiation as opposed to whole breast irradiation. So again, we emphasize the importance of multidisciplinary discussion and also patient involvement. So thank you for your attention. And we'll receive questions at the end.
Thank you, Hélène. We will have time. Thank you for your very wide overview over the de-escalation of axillary surgery, particularly in the upfront surgery setting. We will have time to discuss at the end. Now, I would like to introduce Xin Wang from the National Cancer Center and the Cancer Hospital of the Chinese Academy of Medical Sciences from China, with his talk on insights from China on neoadjuvant therapy and the impact on de-escalation of axillary surgery. So please, Xin, it's my pleasure to welcome you on screen.
Thank you, Dr. Rocco, and very glad to be here to share our experience and in China for this part. I will share my slide in this way. Hold on a sec. Okay.
Perfect. We can see now your screen and your slide.
Okay. So today I talk about from the neoadjuvant therapy to de-escalation of axillary dissection, accelerated surgery insight from China. So as we all know, the incidence between China and the U.S. and Europe slightly different. You know, we have more younger patients, we have more HER2 positive, we have more triple negative patients. Also, we share largest global share of breast cancer incidence because we have we have the very large population. So we have more aggressive subtype, like so that means we have more new adjuvant chemotherapy candidates. And our guideline for ESSO, as you may know, that we decide for the neoadjuvant chemotherapy in three dimensions, like HER2 positive. We have special anti-HER2 drugs. For the triple negative, we have domestic PD-1 data cited, and also we care about the drug access and the insurance. So younger patients with some more aggressive subtype and the unique guideline. So probably we have we have a different aspect for this part. And this is ongoing. This is a Chinese neoadjuvant breakthroughs, and some trials. Most of the trials are already published in very good papers and very good journals, like Lancet Oncology, like JCO, for the HER2 positive, also for the triple negative breast cancer. So, for example, we have HER2 positive. We have de-escalation for this part, like Helen 006, which just published in Lancet Oncology for the 2025. We have almost over 600 patients with some multiple centers in China. De-escalation, we have TCBHP for the PCR rates is over 66% compared to 57. So it's pretty good data. And also for the fascinating, we have used our new ADC like SHR 1811. We just do this, and the ADC alone is almost near to equal chemo and the dual blockades. And we have shared the similar result. So for the new part, like from 1811 to TQB 2102, was just published in GCO in 2025. We got the PCR rate of over 76%, especially for the HR negative part. It's over 22. It's over 92%. It's pretty impressive. It's pretty promising. The data's probably we are now doing the ADC pipeline. It's pretty lead the. I think that the data leads the world actually. And for the TNBC part, for the triple negative part, we do the chemo relief, and we just published in JAMA 2025. We use the first Chinese PD-1 phase 3 in NAC and TABC for the over 400 patients in 40 hospitals, and the PCR rate get over 56.8 compared to 44.7. And also we have BC top and one, that's a new Famitinib anti-genesis the agent. So the PCR rate at over 70%. Also, it's a 13% absolute improvement compared to the treatment we use now. So for this part, we do the immunotherapy pipeline, involves rapidly each generation builds on the last part. And also, we do some kind of genomic tests like precision subtyping. For the TNBC from the Fudan Cancer Hospital, they do the Future Umbrella platform, which divided triple negative breast cancer into 4 parts. For the 4 molecular subtypes, we have RAR, IM, BIOS, and MS. And it's classified by AR, by CD8, and C1. So they published a lot of papers for this, and also for the advanced TNBC, the PFS get improved a lot, and also for the HR positive, they do the platform like they call Linux SNF classification. The SNF also divided into 4 subtypes: classical, immune, proliferative, and RTK activated. So they do the multi-omics integration, like the SNF2 OR, they get a 65% compared to 30%, and also the SNF4 OR, they got a 70% compared to 20%. It's a very big very big progress. It's also used AI-based HE subtyping, so which is also our RCT validation is ongoing. So I believe that the China original molecular classifications is going to be from the discovery to classifier and also to the prospective RCT validation. It's going to be actually the all kinds of breast cancer things. So as I mentioned, the golden era is actually for the accelerated dissection, de-escalation, because we do very precision neoadjuvant therapy, and also we do the molecular monitoring. So like just I mentioned before, the Helen-6, we got a 66% of the PCR rate. Also, we got a 77, the TQB2002. So most HER2 patient achieves YPN0. So it's like for the chemo relief in TNBC, we have almost 60%. For the BC top, we had almost 70%. So TNBC nodes increasingly, cleared. And also for the train, we had a YPN0 rate for the over 95%. So that means that most of the lymph node especially the positive lymph node was becoming changed to negative. So the future trial and the Linux trial, they try to predict who will achieve PCR. So that will guide our surgical extent. That means, precision subtyping to predict response and to personalize accelerated dissection. But for the real practice, that's for the clinical trial part. For the real practice, we do in the real world, actually in the year 2018, we had a nationwide poll that the sentinel lymph node biopsy using rate is just 44%. But now, in the poll of 2022, it's over 76%. And also for this part to SNLB standalone, we had 14%, but now over 40%. And in PCR patients, we have sentinel lymph node biopsy only 23% in 2012, but in the over 2020, it's over 65%. And also for that part, like Z11 accelerated lymph node dissection omission, well, we do like 20% is also increasing. For the dual tracer usage, like 30% in the pool of 2022 year. But now also it's 4 years. It's 4 years ago. Now it's getting more and more better. So that means, SOMB adoption rising fast, and also PCR patient are, we are almost approaching Western levels. So that's the real surgical part. And also for the radio isotype challenge, it is really an issue that the radio isotype was, most of the Chinese hospital lack of this. But we do some kind of derived innovation like ICG fluorescence and like also carbon nanoparticles, and also we do some I-25 and also CLEAP trials instead of this kind of a radioisotype. Like we do in Shandong Cancer Hospital, we do like a CLEAP and I-125. The false negative rate is getting to 5.6%, and especially in N1 specificity, like less than 5%, and also the dual tracer that's less than just a 3.5, so 3.4%. For the Fudan part, they do TAD. They do TAD. The false negative rate is going to be like a 6%, and also the recurrence and there's no kind of recurrence also. That means this kind of technique. Also, we do the carbon. We do just like carbon the TAD and also TAD comp trial. That's it's now it's doing in Peking University. That's that. And these things, they don't have radioactivities. It's more safe, and they have a pretty good false negative rates. And for the false negative rates part, like that's a compare between the 1071, Z1071 or Sentina or Symphonic. We have we have three also Chinese trials. We have smaller amount of patient number, but different way. But the false negative rate, as you see, is less than like 6%. So relatively, so it's I think it's an incredible improvement of this part. So like just Dr. Bog just mentioned, they have a sound trial. They have some kind of omit the lymph node biopsy. We also do this kind of trial, like the SOPAT. We do the lymph node PET before the surgery, and if there's for N0, we omit this kind of surgery, and the 3 years DFS is 100%, and our IFS is 99.7%. Only 2 cases has a accelerated recurrence, so it's a very promising technique using this for the lymph node biopsy omission. And also we have a couple of trials ongoing, like as I mentioned, the SOPAT. We also OMSLMB. We have 114. We have the TEDCOM. We have also some kind of trials. Some of them are single arm, some of the RCT, some of our phase 3 trials to compare this kind of omit of the sentinel lymph node biopsy. So, but the thing is, we have this kind of very good technique, but now there's still a gap. Like we do not include in the like a Texas trial or EU breast trial or Axina trials. So we are hoping for the collaboration, for the opportunity to get the worldwide data to cooperate with you guys. Also like the PCR rate and also the breast conservative surgery. As I mentioned, the national widely, we do more breast conservative surgery compared to before, especially after neoadjuvant chemotherapy, and the rate of neoadjuvant treatments is also getting higher, especially in the HER2 positive patient. Also, the clinical outcome is getting better. 5-year survival is over 80% in the year 2020. So we also do some kind of model accelerated decision making. We do some predicting models, like what using AI, using ctDNA. We do a lot of trials so that we publish pretty good papers in the world journals. Like we do AI and radionomics, like for the accelerated assessment, and also for the ctDNA or MRD for surgical guidance. We do some kind of we do a lot of papers in that research works in China. So the AI imaging, we had an AUC over 0.9, and also for the liquid biopsy, we have 100% MPV, which means it's pretty. So we have a very good prediction of the axillary. So that's also basis for the de-escalation of the axillary surgery. Now also we had, just to mention before, we had the largest population in the world. So we had the largest, I guess it's the largest cancer center. I mean, like Fudan to do over 11,000 breast cancers a year. Tianjin also over 11,000. For us hospital, I came from National Cancer Center, so also over 6,000 cancers, breast cancers a year. So as I mentioned, we absent from a lot of countries, a lot of trials world trials, but we can bring some patients well, and we can bring novel drugs, and also and radiomics data, and also new innovations. Probably we can getting from this ESSO, the CSO webinar, we can have a platform to building these bridges. We had to do more cooperation. So for the last part, as for my speech, China has a world-class neoadjuvant evidence with the Chinese development drugs. We had a lot of drugs, as I showed before, a lot of trials had done. And also China detected accelerated escalation feasible with a false negative rate less than 10%. We had also a couple of trials to prove that. And also precision subtyping and personalized surgery is the next frontier. We had a platform of the China's original molecular classification and also predictive models. So it's ready to contribute and collaborate in the global precision axillary area. And for the future vision, from the precision and neoadjuvant chemotherapy to precision axillary surgery, to my point of view, actually the convergence for three Chinese strains, like from predict and to personalize the neoadjuvant chemotherapy, actually, and then to access axillary response to guide surgical extent, and also monitor residual disease to escalate or de-escalate the axillary surgery. So our goal is not just a less surgery, it's the right surgery for the right patient, and guided by the molecular precision rather than anatomical conditions. So thank you all. Thank you for listening. Thank you.
Yes, thank you, Xin. Yes, I completely agree with you. This is the right platform to create network between Europe, all around the world, between Europe and China. So this is the exact way to create bridges. And I think that you are completely right. You should be part of the Axana collaboration, because I noticed, I didn't know about the possible use of carbon particles for TAD. So your experience would be extremely useful to increase the significance of the data of the Axana trial. So I noticed that you both use dual tracer, but without technetium, without radioisotope, and targeted axillary dissection using iodine seeds and carbon particles. Could you specify on this? Could you further say something about the use of carbon? How do you use carbon to target the positive lymph node, or in other ways?
Okay.
Yeah.
It's a very good question. Just we just only a few center. We have kind of a radio the carbon the radioisotope, but most of the Chinese center they don't have. So we do this carbon to use this carbon to instead of dye blue. It's to trace of the sentinel lymph node. No,
but does the carbon migrate, or you put within the lymph node?
No, we just put with the dye blue, just the same thing. We just put into the we do the injection into the breast, and then it might migrate to the lymph node. Sentinel lymph node. Yes.
This is very, very interesting. I see that Mario Giuliano raised his hand. Do you have a question for Xin?
Yeah, Nicola, if I may, I would like to ask a question to Xin. And I really enjoyed your talk, Xin. And you showed us very impressive results in terms of pathologic complete response with de-escalated treatments, mostly in triple negative and early and HER2 positive early breast cancer. What about luminal breast cancer? Because we see that there is not enough efforts to develop new tailored treatment alternative to chemotherapy, at least in the registrative trial so far. I didn't have the chance, I didn't have the time to show also the result of chemo plus immunotherapy in high risk luminal breast cancer. What's your view about the development in this sense in neoadjuvant treatment for luminal breast cancer?
Okay, thank you, Dr. Giuliano. And we show a lot of data for the triple negative and also HER2 positive, as we all know. But for the luminal, it's not very sensitive to chemotherapy, as we all know. But sometimes endocrine therapy we have time is limited. I didn't show. There's still some trials for the triple positive. The breast cancer. Yes, we had endocrine therapy plus chemotherapy and also plus anti-HER2 therapy. But the PCR is actually relatively lower than that's two kind of subtypes. Well, as I mentioned, they have SNF, the Fudan Cancer Center. They have the SNF classification. They divided into 4 parts of the subtype. So some of them are sensitive to immunotherapy, and some of them are sensitive to ARs or something. So, as our center, we are doing now a clinical trial. We do kind of chemotherapy plus immunotherapy and also radiotherapy before surgery. So a neoadjuvant radiotherapy. So we plus this to like a new check rate from the Europe. We do similar trials. So, but now it's an ongoing trial. So probably we can show the data later. Thank you.
That's very interesting. Thank you.
Thank you, Xin. So, Mario, you showed very interesting data about the use of genomic testing, not only for luminal cancers, but also for triple negative and for HER2 cancers. But do you think that thanks to this genomic testing, in particular for HER2 positive cancer, we can aim to a future of neoadjuvant treatments without chemotherapy in some subtypes of patients?
Yeah, thank you so much for this question, Nicola. I'm not sure we can, for now, we can avoid chemotherapy, but there are some preliminary evidence, very interesting, from a phase 2-3 trial, the FAIR-GAIN trial, showing that maybe adding to the baseline phenotyping, also the radiological evaluation during the treatment, we may start a chemo-free treatment according to biological phenotype, baseline biology phenotype, and then follow with the imaging the tumor. In case of response, continue with the de-escalated chemo-free treatment, and in some cases achieve a pathologic complete response. So I think that there is the possibility. I'm not sure it's going to be very, very close, but for sure right now we need to develop and to introduce in our clinical practice all the de-escalated chemotherapy backbone that we have been demonstrating, to be very effective and much less toxic so far in clinical trials. So the answer is yes, maybe in the future, and maybe adding the information from biology and from real-time imaging. Probably this could be, the strategy to move forward in order to avoid chemotherapy also in HER2 positive breast cancer.
So real-time assessment during the therapy to see if we can still de-escalate.
With the breast imaging and PET PET scan.
Mm-hmm.
That
Yes,
was
according to PET scan, I also appreciate the results of the SOA-PET trial from Xin. So Hélène had presented the results of the sound, of the enzema, of the book 18, and we also have the evidence from the SOA-PET from China. So PET scan could be also an option to better assess the axilla before surgery. We know that the key element is the assessment, the clinical and radiological assessment of surgery before any decision for that specific patient. And PET seems to be a useful option for this patient. But could we consider a PET scan for all T1 and 0 patients? It seems like to be a great an overuse of PET. What do you think, Xin?
Okay, thank you for your it's only a clinical trial, so I mean the SOA-PET, but now also myself is doing also a similar clinical trial, but we now use not the PET for the whole body. It's only for we had to do the lymph PET for the lymph node, for the breast and the axillary. So that's not for it's not for everyone. It's clinical trial, but we just improve we did not use FDG 18. We just improve them kind of breast for some kind of how to say targeted for the breast cancer for the new radioisotope for the PET. So we developed this, and it's also for the breast for the breast part and the lymph node part. So
yeah, thank you for clarifying. No, it's very clear. So we are running a little bit late. I have just one last question for Hélène before closing, and thanking all of you for participating. Hélène, what about de-escalation and omission of axillary surgery for the lobular cancer? Can we also apply all these results to lobular cancer, or it's more risky?
They didn't really look at the difference between what kind of cancer it is. So they focused mostly on the hormone receptor positive and HER2 negative. So far, we just focus on those criteria. With lobular cancer, it's more difficult to be picked up. Even, for example, using imaging MRI, it won't really, you can't really comment on any metastasis. But I think overall, the real answer is we don't have data yet because it wasn't clarified. But I think it won't make any difference as regards biology, because there are other factors which play a major part.
Yes, anyway, I would feel a little bit more uncomfortable in omitting surgery in a lobular cancer, only because we have less predictable imaging before surgery for lobular cancer. This would be the only reason, even if biology is always king, we know.
Yeah, Nicola,
okay.
If I have just a few seconds, like in lobular cancer, it's very interesting also for the indication to CDK4/6 adjuvant CDK4/6 inhibitors. Actually, recent evidence from San Antonio Breast Cancer Symposium in 2025 showed that in lobular cancer, up to 18% of clinically N0 patients showed N-positive disease. So maybe the entire de-escalation of surgical approach, of nodal surgical approach, should be seen with caution, at least for now, at least until we have indication to adjuvant treatment according to nodal status.
Yes. Thank you, Mario. I think we are running really late now. I would like to thank you, Mario, Hélène, and Xin, and all the people who joined us from China, from Europe, and from all over the world. And I would like to thank ESSO-CSO and JMed for this joint webinar. And I hope that all of you could continue following our educational activities with European Society of Surgical Oncology. So thank you, and see you for the next event.
Thank you.
Bye-bye.
Thank you. See you. Bye-bye.
Thank you, Xin. Thank you, Hélène. Mario.
Thank you.
Bye-bye.